Hello, everyone, and welcome to today's webinar for Mental Health Professionals, Written Exposure Therapy, a Brief Treatment Approach for PTSD. My name is Sasha Sicard, and I am the Education and Membership Manager here at ADAA. Welcome, everyone. Before we get started, I would like to go over a few items so you know how to participate in today's webinar. We've taken a screenshot of an example of the attendee interface here. You should see something that looks like this on your own computer desktop in the upper right corner. You have joined the presentation listening to your computer's audio by default. If you would prefer to join over the phone, just select phone call in the audio panel and the dial-in information will be displayed. Please note this webinar is being recorded and will be available as an on-demand webinar within 24 hours. All attendees should ensure they remain muted for the entire presentation to avoid background noise and distractions. You will have the opportunity to submit text questions at any time of the presentation by typing your questions into the chat box of the control panel. You may send in your questions at any time. We will collect these and address them during the Q&A sessions at the end of the presentation. For those who purchase CE or CME credit for this webinar, you'll receive an email with a link shortly after the completion of this webinar. This link will include the webinar survey, post-test questions, and post-test questions required to receive a CE or CME certificate. Please reach out to webinars@adaa.org if you have not received this at the end of the webinar. I would now like to introduce our presenter, Dr. Denise Sloan. Dr. Sloan earned her PhD in clinical psychology from Case Western Reserve University. She is the Associate Director of Behavioral Science Division, National Center for PTSD, and a Professor of Psychiatry at Boston University School of Medicine. She is an expert on psychosocial interventions for traumatic stress disorder and has a specific interest in efficient treatments for PTSD. Dr. Sloan conducted a long line of studies that led to the development of written exposure therapy. Since developing the treatment, she has conducted several studies examining its efficiency. Dr. Sloan has published over 100 journal articles and co-edited 2 books. She serves as editor-in-chief of behavioral therapy and is consulting editor for 6 scientific journals. Thank you for joining us, Dr. Sloan. There will now be a brief moment of silence as I pass over the presenter role to her.
Okay, can everyone see my slides okay?
Yes, we can.
Okay, great. All right, thank you so much, everybody, for coming here today. I very much appreciate everyone's attendance, and I want to make sure that we get through what I want to talk about and then have time left for questions that people might have. So I'm going to be giving an overview of written exposure therapy and basically talking about how we developed the treatment and some of the efficacy findings that we've obtained so far. And then I'll end with just describing some of the ongoing studies that we're doing and future directions. Oops. So I just want to first just point out, like, why do we even need another treatment for PTSD? Because we do have a number of very effective treatments available. But there have been some problems with these treatment approaches that are currently available. And the problems are both from the provider side as well as the patient side. So from the patient side, about 1/3 of the people that seek treatment for PTSD drop out before completion. And they usually drop out early in the course of treatment. So it's not the case that they're dropping out because they feel better. And these rates are even higher in places like the Department of Veterans Affairs and Department of Defense, where approximately half of the people drop out. That's quite high. And when asking patients why they're dropping out, they often report that it's just too much, that it's too much time, and they have too much homework between sessions. And given the other demands that they have going on in their life, they just feel like it's difficult to get through all the sessions. From the provider side, we have a number of providers now that are trained in both cognitive processing therapy and prolonged exposure. Those are the two treatments with the most evidence base to support their use for PTSD. And especially in the VA and DoD settings, we've trained now over the past 10 years or so, 15 years, many providers across the system in CPT and PE. And in more recent years, we've been doing implementation studies to see how often are providers using these treatments after they've been trained. And what we're finding is that they're not using them very often. And when asked like why they're not using these treatments often, what they indicate is that they do like the treatments, they think they're effective, but they don't feel like they have enough time to use these treatments given the number of people that present for treatment to their clinics, as well as the number of staff that are available to see all the people. So what are they doing instead? They are tending to do supportive care, like basically checking in with people, seeing how they're doing, maybe giving them some general coping skills. But those kind of treatment approaches are not effective for PTSD. So it's become a real problem. So when thinking about what are some alternative approaches for PTSD treatment, there's a couple of things that are really important. And one is that no matter what we do, it should include some exposure to the trauma memory, because that appears to be a pretty critical component to successful PTSD treatment. And the second is that it should be efficient for both providers and the clients. Based on what we've seen for barriers to both accessing and delivering care, whatever we do, it should be efficient to make sure that patients stay engaged in the treatment, as well as providers being willing to deliver the treatments. And that brings me to written exposure therapy. And the way that we started doing this treatment was actually not thinking that we were developing a treatment at all. We were interested, Brian Marks and I, in something called expressive writing by James Pennebaker and his colleagues. And this is a procedure in which people write generally for 3 times, 20 minutes each time, about the most stressful or traumatic experience that they've had in their life. And this was the first study in 1986, the screenshot I have here of the paper, published in 1986, of written exposure therapy, or expressive writing or expressive disclosure. And what they find is that generally people have really good outcomes from this very brief intervention. They have good outcomes both in physical health and psychological health. So physical health, they get sick less often after just writing 3 times, 20 minutes each time. And their immune functioning is improved. And psychologically, their mood is better. And they feel better and their well-being ratings are higher. That is pretty astounding given that it's just 3 sessions, 20 minutes writing each session. And this study, this procedure has been replicated now probably 1,000 times with all kinds of different populations, including cancer survivors, people with rheumatoid arthritis, and it's a pretty consistent, robust finding. So Brian Marks and I were really kind of intrigued by this, like something that could be so brief and have such good outcome. And that was intriguing to us. But it also struck us that this is very similar to imaginal exposure. You're asking someone to repeatedly write about the most traumatic thing that's ever happened to them with as much emotion as possible. And so that's like imaginal exposure. But we didn't think that it would be, if you used written disclosure procedure with people that had PTSD, at least moderate PTSD symptoms, and a criterion A event, which is required for the diagnosis of PTSD, we didn't think that doing expressive writing would be efficacious for them. And we thought that for a couple of reasons. One is that given what we thought we knew about PTSD treatment, that you needed much more of a dose of exposure to get good outcome. And at the time, and this was in the early 2000s, at the time, the prevailing theory of why PTSD treatments worked had to do with an exposure model. So in exposure, it's pathological fear reduction that you're trying to get. So what you're trying to have happen is a person has a pathological fear response. So their response to a stimulus is out of proportion of the danger that's actually present with the stimulus. In the case in PTSD, that's someone's trauma memory. So their response to their trauma memory is much more out of proportion to the actual danger of just thinking about a traumatic event. So what you want is to have someone engage in the memory. So that's initial activation where they're going to have a fear response. And then with repeated exposures, they would have this extinction of the fear response. So it would decrease over time as people learn that there's nothing to be fearful of, that they can tolerate feeling negative affect, and there's no danger present. So we thought expressive writing would not work for people with at least moderate PTSD symptom severity and had been exposed to a criterion A trauma event, because we didn't think that 3 sessions, 20 minutes of writing each session would be a sufficient dose for the extinction of pathological fear responding. So we set out to test this hypothesis, and we used as our comparison condition the same procedures that James Pennybaker generally uses, where we had the people write about how they spent their time each day with no emotions or opinions. So we randomly assigned people to either an expressive writing condition or a control condition where they wrote about how they spent their time each day. So this is just a visual display of what we found in that first study. This was published in 2004. Much to our surprise, we found that people, in fact, did have a significant reduction in PTSD symptoms if they wrote about the trauma event. And that is in comparison to the control condition as well as from baseline. So we didn't even just want to look at this because we weren't so much interested in the outcome as much as the process. So we were looking at that extinction effect. So we looked at that as well with both self-reported emotion as well as salivary cortisol. And this is a display of the self-reported emotion. Well, we had them write, after the end of each session, what their negative affect was. And so you can see that there was initial activation at the first session. So people that wrote about their traumatic experience had initial higher negative affect at the first session. But by the third session, they weren't significantly different than the control participants. And that reduction in fear response also predicted their outcome. So the more they had a reduction, the better their outcome in PTSD symptoms. And we found a similar pattern with salivary cortisol as well. They had initial activation, but it quickly extinguished, and they looked good, no different than the control participants by the third session. So that was very surprising to us and not at all what we expected to find. And we didn't really quite know what to make of it. So at that point, we realized that we had just assumed that we knew a lot about how much of a dose that we need for PTSD treatment outcome. And we wanted to go and look at the literature to see, well, what's actually been studied in terms of this. And what we found, and again, this was in the early 2000s, was that no one had looked at this question up to that point. So in 2006, it was the first study that was published that looked at this dose question. It was a non-randomized design where people coming into a clinic for PTSD treatment, the clinic gave PE to everybody, prolonged exposure. And the standard dose of PE is a 90-minute session. And the clinic did 10 sessions generally for people. But some people couldn't afford those 90-minute sessions. So for those individuals, they got an hour session. So of that hour, they were getting about 30 minutes of imaginal exposure. The standard dose, if it was a 90-minute session, they were getting 60 minutes of imaginal exposure. And what you can see is it didn't make a difference. So everybody got 10 sessions. It's just how long each session was. And if you reduced the session by 30 minutes, you still got the same kind of outcome. So this was the first study that was actually published looking at this dose question. That study was basically replicated but with a randomized design and published in 2015. And this was an even shorter imaginal exposure session that consisted of 20 minutes of imaginal exposure compared to the standard dose of 60 minutes. And in this study, they found that there was also not a difference between the people that got less of a imaginal exposure dose. These findings are particularly important because for prolonged exposure, I'm sure anybody that works in a clinic knows it's very difficult to accommodate a 90-minute session. It's not only difficult for a clinic, but also patients are less willing to do 90-minute sessions as well. So knowing that you can reduce a PE by to a 60-minute session instead of 90 minutes is very important. And there's even be some evidence that cognitive processing therapy, you might not need as much of a dose as well. So this was a study published in 2012 by Tara Golofsky and colleagues, and they found using a variable length format of CPT that almost 60% of the sample needed less than 12 sessions. I think it is notable to see that about a third of the population needed more than 12 sessions. But these studies in general are accumulating to indicate that we really don't probably need as much as what we thought previously of a dose of treatment for PTSD to get good outcome. And that's what we were finding too with the expressive writing procedure. So going back to this line of work that we conducted, the next study that we wanted to do was that expressive writing allows people to write about the same memory each time, or they can write about a different life event. And that's not entirely consistent with an exposure model, which indicates the importance of writing repeatedly about the same stimulus event. So for this PTSD treatment, you really want someone to write about the same trauma memory each time to get good outcome. So we wanted to test whether it made a difference if people wrote about the same trauma event each time, or they wrote about different trauma events. And that was the next study we did. So we took, again, people that had multiple criterion A events and had at least moderate PTSD symptom severity. And we randomly assigned them to one condition where they would write about the same trauma event each time, a second condition where they would write about different criterion A events each time, or a control writing condition. And in that study, we found that only people that wrote about the same trauma memory each time got good outcome. They had a significant reduction in PTSD symptom severity. And the people that wrote about different trauma events each time looked similar to control participants. So they really didn't have a reduction in their symptoms across time. So what about this extinction effect? So this is self-reported emotion ratings. We looked at both this and heart rate in the study, and the findings were similar. And what we found was that both trauma writing groups did have a significant reduction across the 3 sessions in their negative affect ratings. But the people that wrote about the same event each time got an even better, more significant reduction in their negative affect ratings, to the point where they were not different from the control participants. Whereas the people that were writing about different trauma events each time were significantly elevated compared to those other 2 conditions. We interpreted this finding as that if you had somebody continue to write about different trauma events each session, eventually they probably have good outcome, but it would take a lot longer to get there. And really what we want to try to do is get people to have the best outcome possible in the shortest amount of time. And to do that, we think that these findings illustrate the importance of staying focused on the same trauma event each time. So we did a lot of other studies. This was basically over a 12-year period that we were doing studies to try to better understand expressive writing and how to get good outcome. We did studies where we looked at changing the instructions to focus on emotional expression versus meaning making. We looked at moderator effects, like did women do better than men with this? We found that that was not the case. And then we got to a point where we wanted to look at people that actually meet diagnostic criteria for PTSD. Because prior to this, we were using a self-report measure, and including people if they had at least a moderate symptom severity. And there was a wide range of people in all the studies, but there were certainly people that probably met criteria and certainly people that probably did not. So we wanted to do another study where we looked at expressive writing for people that meet diagnostic criteria. We confirmed whether or not they had PTSD using a semi-structured interview. And so we used the same expressive writing procedure with one exception. We changed the instructions so that the people had to write about the same trauma event each time. So we randomly assigned people to either the expressive writing or to the control writing condition. And in this study, we found basically what we thought we were going to find in that first study, that people did not get improvement. So it didn't matter if they wrote 3 times about the same event. They did not have a reduction at all in their PTSD symptom severity, and they looked just like the controls. So when we looked at their fear reaction, this time we were looking at heart rate. We can see here that they had initial activation of response. So they were activated initially, but they remained activated at each session. So they never came down, they never had an extinction of that response. So this study, this last study, was exactly what we thought we were going to find in the first study, but we are glad that we didn't do that study first, because we would have just said, see, you need much more of a dose, and we would have moved on. But because we had done all these other prior studies, we knew that there was something here, but we had to tweak it. And we learned a lot from this study and all the studies leading up to it. So we certainly thought we needed more of a dose of exposure writing to get good outcome for PTSD. We also realized that in the expressive writing procedure, nobody is told like why they're being asked to write about their life events or why this might be important. And one thing that we definitely know from psychotherapy in general is that buy-in has a lot to do with outcome. So if a client doesn't know like why they're supposed to do what they're being asked to do, they're not likely to follow the instructions, and they're not likely to get any kind of good outcome. So it's really important that we provide a treatment rationale, especially when it's something that the person is trying hard not to do every day. It's important to tell them why we think it will be important for them to write about their trauma event and how this is going to help them. And then the other thing that we realized is that particularly people that had a diagnosis of PTSD, we would tell them the instructions of how they were to write, but then it was up to them to do it or not. And there's no feedback that's given in expressive writing about whether or not someone followed the instructions or not, or how to get back on track. And we were finding that especially people that had a diagnosis of PTSD, they weren't always good with following the instructions. So sometimes they would just write kind of around the event, the peripheral aspects of the event, but wouldn't write about the details of the event itself. And we wanted to make sure that we changed the way that we approach this to really get course correct and get people back on track if they weren't following the instructions. So we altered expressive writing in a number of ways. We added psychoeducation of PTSD to the first session because all good treatments for PTSD include this. So basically, what is PTSD? What are the symptoms of PTSD? What maintains those symptoms? And then that leads nicely to a treatment rationale. So given what we know about PTSD and what maintains it, this is what we're going to do in the treatment, and this is why it's going to work. We increased the dose to 5 sessions, 30 minutes of writing each session. And we increased it, not pulling it out of a hat, but we did pilot work and where we examined what was the necessary but sufficient dose of writing to get good outcome. And we found that 5 sessions, 30 minutes was that dose. And then generally we give directed writing instructions to write about a specific event with a focus on both the detail, like what happened, as well as the emotion that the person felt at the time of the event and the thoughts that they had during the event. So we've renamed it, we call it written exposure therapy, just to kind of represent that it is quite different than expressive writing. But this isn't a new treatment. We think this is a treatment that's been around a long time. It is a marginal exposure, but it's repackaged in a way that is efficient and we think tolerable. And the reason I say it's tolerable is because it's a short duration. And as you will see as I present some of our efficacy findings, our dropout rates in the treatment studies we've seen or conducted are quite low. So the average dropout rate, as I mentioned at the beginning of the presentation, for PTSD treatments is about 36%. It's higher with veterans and service members. And we have found much lower dropout rates for written exposure therapy. I didn't mention, but there's no homework either. So we don't have any worksheets for people to do in between the sessions. And we think that that's also part of why we have low dropout, that people don't need to worry about like doing homework. They just come to session and that's it. We found good outcome without homework, so why include it? So at this point, written exposure therapy is included as a recommended or first-line treatment approach in the Department of Veterans Affairs, Department of Defense, clinical practice guidelines for PTSD. It's included in a section called written narrative exposure therapy. So it's one of several examples of written narrative exposure therapy. And this is just a snapshot of the cover of the treatment manual that was published in 2019. We waited some time to publish the treatment manual because we wanted to have more evidence to support its effectiveness. And so once we had sufficient evidence, we went ahead and published that treatment manual. So now I'm just gonna talk a little bit about some of the empirical support. After we developed the protocol, we wanted to test, like, does it actually work with people that have a diagnosis of PTSD? And our first test of the protocol was published back in 2012. And we focused on a sample of people that had PTSD from a motor vehicle accident. And we chose motor vehicle accident because it's surprisingly the most common way that people, especially in the US, develop PTSD. So it's quite prevalent. And we wanted to start with one specific type of PTSD type and decided like motor vehicle accident would be a good one to choose given how prevalent it is. So in this study, we took a small sample, 46 people, and randomly assigned them to either written exposure therapy or a waitlist control. And of the 22 people assigned to written exposure therapy, 8% dropped out. So that's quite low. And we did an intent to treat approach. So we tried to get everyone back. Surprisingly, everybody actually did come back. And I'm sure that will never happen to me again, but that was good. So this was our outcome findings. So you can see that people assigned to written exposure therapy had a significant reduction in PTSD symptom severity. This was by blinded assessors who didn't know what condition people were assigned to. So these reductions were huge and maintained out to 6 months. And one of the things I want to point out on this graph is that most of our treatment gain isn't even seen by post-treatment. So we do the post-treatment, but we repeatedly have found in our studies that people continue to have reduction out to about 3 months or so. And I'll be pointing that out in subsequent studies I'm going to show you here. So these were significant reductions. It is the case that we compared them to a no treatment comparison, and it's not hard to find a significant between condition effect when you're comparing some kind of treatment to nothing, but these reductions were quite large. And when we looked at how many people had still a diagnosis of PTSD, only 2 people out of those 22 still had a diagnosis. That's quite low, and certainly lower than what we saw for waitlist condition. By 6 months, nobody still had a diagnosis of PTSD. And one of the things that we observed in the study that I think was quite notable and important is that all we really did in the treatment was focus on doing a repeated exposure to the trauma memory. But what we were finding is that people would leave the sessions and come back to subsequent sessions telling the therapist that they had done other exposures in between the sessions. So the most common type of avoidance for people with car accident PTSD is driving and riding in a vehicle. And you can see this is a driving and riding avoidance measure that over time, people in the treatment condition, written exposure, had a significant reduction in their driving and riding avoidance behaviors. And that's pretty incredible since we weren't instructing them to do in vivo exposures or developing hierarchies. They were just spontaneously doing these exposures on their own. So what we think was happening and what participants would talk about was that they were finding writing about their trauma memory to be helpful, and they were deciding, like, I can do this, maybe I should start confronting other things in my life that I'd been avoiding, and then just taking it upon themselves to do that. When they would tell the therapist that they were doing that, the therapist would really praise them, but not give them instructions for continuing to do it or how they might do other exposures. And it's pretty miraculous that the findings were sort of generalizing outside of the session. So this is a graph that I just created because our between condition effect sizes were comparable to what's been seen for cognitive processing therapy and prolonged exposure when those treatments have used a comparison condition that's either control, minimal attention, or a wait list. And so this was a study by Patty Rezick in 2003, where she directly compared PE to CPT with a minimal attention condition. And she used the same outcome measure that we had used in that first study. And so we just plotted written exposure findings on the same graph to illustrate that the outcome findings are comparable. And these initial findings led us to want to test written exposure directly to one of these treatments that have been well studied, either CPT or PE. So in our next study, we wanted to see, is written exposure non-inferior to a first-line PTSD treatment that's a lot more intensive in terms of both dose and homework assignments. So even though written exposure is fewer sessions, can we get the same kind of outcome findings? So we did that study and published it a couple of years ago in 2018. And in that study, we directly compared written exposure to cognitive processing therapy. And this is the protocol version that includes written accounts. We randomly assigned 126 people evenly to those two treatment conditions. And you can see dropout for written exposure was 6%. It was 25 people in total, 39% in CPT. But of those 25 people, 19 had dropped out by session 5. So that's a more fair comparison to written exposure therapy. And that is indicative of generally trauma-focused treatments, that if you're going to drop out, it's usually going to happen in the first handful of sessions. We used an intent to treat approach, so we tried to get everyone back, whether or not they dropped out of treatment, and we did well with that, and it was comparable return rate across those two conditions. So this is a visual of what people looked like across our assessments. In this study, we wanted to standardize when we did the assessments across time, because if we did a post-treatment, when people would be assessed at CPT would be much later than when people are assessed at written exposure, and it would be hard to compare those two. So we did our assessments when we thought people would be done with written exposure at 6 weeks, when we thought they'd be done with cognitive processing, 12 weeks, and then have several follow-up assessments. And we did find that it was non-inferior. We used the 10-point non-inferiority margin on the CAPS-5. And the actual difference, the biggest difference between the two conditions was just over 4 points on the CAPS, which is quite small. This is just a table that highlights what the difference was. So at 24 weeks, it was the largest difference between the conditions, but it was non-inferior. And it actually got smaller across time. And just to show what treatment completers look like, it was basically the same, and it was also non-inferior. The biggest difference was, again, 24 weeks, and the difference was about 6 points, which is, again, within the non-inferiority margin. So those findings were kind of surprising us as well. We were hopeful like that it would compare well to CPT. but I think it was quite encouraging how well that they did. The other thing that is important to know is this isn't entirely understood, but a lot of people who have done CPT and PE, one common finding that is obtained is that service members and veterans do not do as well in these treatments. They do certainly get good outcome, but they don't get as good of an outcome as what we see with civilians. And what I'm showing you here is a snapshot of a review paper that was published in 2015, summarizing the outcome findings for CPT and PE with veterans and service members and how that compares to civilians. So the next study that we did that we just finished, it's not published, so you guys are getting to see it before most people see it, but we wanted to compare written exposure to cognitive processing therapy with active duty service members to see how well does written exposure do with a population that's generally pretty difficult to treat. So in this study, we randomly assigned 170 men and women service members to either written exposure or CBT. This time we used the version that's cognitive only, so it removes the written accounts. There's some thought that people might do better in CBT without written accounts. The dropout rate might be lower. So we used this version to see, if there would make a difference. So in terms of dropout, I'm showing you two graphs here, and one is on the left by dropout by session 5. So for written exposure, this is the highest dropout rate we've observed. So 24% dropped out. That was exactly the same as a dropout rate for CPT-C by the 5th session. The graph on the right is CPT-C for all of it, so all 12 sessions. And you can see that their overall dropout rate is 45%, which again is not that different than what is generally seen for a service member sample. So how did they do in terms of their outcome? This time, if you remember the first study that I showed with the primarily civilian population, it was just over 4 points was the biggest difference. And that was surprisingly about the same here. So 4.23 was the largest difference between the two conditions. And that is, again, non-inferior. So written exposure, but everybody got better and they got significantly better. And there wasn't a difference, again, in the two conditions. When we looked at the completer sample only, which is particularly important with 45% dropout in CPT, we also find that there is not a significant difference. It's within the non-inferiority margin. It's just slightly higher than the intent to treat sample. So we've now replicated basically these findings for written exposure being non-inferior to a more intensive first-line treatment approach with the service member sample. So we have a number of future directions, and some of these things are ongoing. One of the things is we need to better understand for who written exposure therapy is effective. We don't really know very well or very much about moderator effects, who tends to do better in cognitive processing therapy and prolonged exposure, but we do know there is variability in how people respond to these treatments. And we have looked at moderators for the first study that we did comparing written exposure to CPT, and we looked at all kinds of severity factors, male, female, and we didn't find any moderators for written exposure at all. But we want to continue to look at that because the service member sample in particular had huge variability in how people responded. So if you just looked at the average of their outcome, it really masks how much variability was happening in both CPT-C and written exposure. So we definitely, that's our next step, is to look at moderators. And then we have a number of ongoing studies of looking at the effectiveness of written exposure therapy. One is looking at a non-inferiority study of written exposure compared to prolonged exposure. So this is great and exciting because it's two exposure-based treatments, one that's much more intensive than the other. And we're doing that in the Department of Veterans Affairs, where about halfway through, we plan to randomize about 150 people. We've randomized about 70 people to date. So we're excited to see, what that looks like, and if we still see non-inferiority for written exposure when we compare it directly to prolonged exposure. The other study that's about to start is funded by the Patient-Centered Outcome Research Institute, and it's a study where we're comparing written exposure to antidepressant medication among people with PTSD who present to primary care settings. So the most typical place that people with mental health issues present is not to mental health facilities, but instead to primary care. And they're not very likely to take referrals for mental health treatment if they're given those referrals. So treating them where they're at in primary care is the best place to kind of treat them and get them the treatment that they need. But you can't really do more intensive PTSD treatments in primary care because usually it's a max of like 6 mental health treatment sessions. Written exposure therapy could fit that. So we're trying to see, can we treat people with PTSD in primary care, and how does written exposure do compared to antidepressant medication? So that is a study in which they plan to recruit about 1,400 people. There's both community clinics involved in that as well as the VA clinics, and that'll be a study where we can directly compare community people to veterans. So I think that'll be great as well, and maybe provide a better understanding of why those two populations tend to respond differently to treatment. And then the other study that's ongoing is a study where we're treating people during a psychiatric inpatient stay. So people that have high risk for suicidality, who end up being hospitalized, their highest risk for acting on suicide is immediately following discharge. So the 30 days following discharge is their highest risk period. So if we can get them some kind of treatment while they're in the inpatient unit, psychotherapy, that could potentially reduce their suicide risks. And that's what we're trying to do in this study. It's also with service members. So we're giving them written exposure therapy during their hospitalization stay. We are doing sessions either daily, sometimes we do it twice a day, depending on their length of stay. And then looking to see not only their PTSD symptom severity following their discharge, but also is their suicide risk and suicide ideation reduced as well. And then the other study that's ongoing, we're about in a third year of doing this, is rolling out written exposure in the Department of Veterans Affairs to mental health providers. So we're trying to better understand what model of training works best for people. And we don't think it's a one-size-fits-all model. So we're looking at whether people have experience in trauma-focused treatments or not, and how much of an intensity of a treatment model or training model do they need to get good outcome. And so we're very much in the midst of doing that, and it's going well, and we're learning a lot, and we're hoping to kind of integrate some of the findings and what we're learning to spread beyond the VA. And then the last thing I would say in terms of our future directions is just trying to better understand why not only written exposure, but other trauma-focused treatments work. We have hypotheses about why we think these treatments work, but we don't have a lot of good, clear findings to kind of lead us to are our hypothesized mechanisms actually in play? And it's probably the case that there's more than one reason or underlying mechanism. I also think it's probably the case that a specific treatment might work differently for different people. So whatever one mechanism might explain why it works for one patient, but it might be a different mechanism for another patient. And that, I think, as a field, is an important place for us to focus our efforts. Because if we understand why these treatments work, we could do better patient matching, number one, but also really kind of focus in on what are the core components of these treatments and perhaps make them more efficient across the board. So that's kind of a speed through version of written exposure, and I wanted to definitely make sure that I left sufficient time for questions. So at this point, I will take the questions.
Hi, thank you so much. That was wonderful. Let me just pop up our Q&A screen. Ooh. Okay, we have some great questions, Dr. Sloan.
Good.
So one of them asked, when the clients are doing the written therapy, does it matter if they're handwritten or typed on a computer?
Yeah, so that is an excellent question and one that we're asked all the time. So I don't have empirical data to support this, but we always have them do it by handwriting. And I think some patients are like, come on, I really like to type. I'd rather just type it. And the reason that we do handwriting is that I think there is something important about slowing down the process.
Mm-hmm.
What we really want them to do is engage in their trauma memory and really think through, like, what happened? What was I thinking? What was I feeling? And if people type, there's two potential issues that can happen. Either they're really good at typing and they're speeding through it and not really thinking about the memory itself, or they're really bad at typing and that, cognitive resources that are taken up by thinking about where's this letter on the keyboard takes away from them engaging in the trauma memory. So I should also say that we think about these sessions as being a springboard. So it's not just what they're doing in the session, but we want them to continue to allow themselves to think about the trauma event in between the sessions as well. Um, and if they do that, then they're learning the skill of, like, just to have the thoughts and feelings rather than avoid them. So it's, even if they don't finish writing about the whole thing in one particular session, they probably won't if they're doing a good job with it. They do have other sessions to write about it. Um, but yeah.
That's great. Thank you so much. We also got another question that says, are there any findings yet with regarding the WET effectiveness with people who have complex and multiple traumas?
Yeah, another great question. So that study where we compared cognitive processing therapy to written exposure, both in that study and the one with service members, there were quite a few people that I think would have been characterized as complex PTSD. And in fact, most people that have a diagnosis of PTSD have multiple index trauma events, criterion A events in their lifetime history. And but in both of those studies, we had quite a few that would have been, I think, defined as complex PTSD. And that was one of the things that we thought would be a moderator. And we have not found that to be the case. So it seems to work just as well with people that have severe trauma histories, childhood trauma events, what would be defined as complex PTSD, as those that have just like a single event.
Great, thank you for clarifying. We have a question that they want you to comment on the instruction to write about the trauma from the participant's perspective today versus writing as if it's happening now, and how you decided on that.
So yeah, I have a longer talk, and I have slides that kind of address that, but I took it out to try to get 45 minutes in. So thank you for asking that question. So we actually pulled from the literature that primarily has been published in social psychology. There is quite a extensive literature showing or documenting that when people think about very, highly negative life events that have happened to them, they do a much better job of thinking about those events and analyzing them when they take a distance approach versus taking a immersed approach. So immersed is, imagine it's happening right now, you're looking down upon it happening, versus like it's in the past, and as you look back upon it now. And so we have integrated that into our writing instructions based on this literature that shows that people do a much better job in terms of analyzing and thinking through. We also think that's one of the reasons that written exposure is pretty tolerable, because it's not actually happening now. And I think that's an important distinction for clients. Like, this isn't happening now, you're thinking back upon it. Even with that distinction, people still feel like it's pretty intense, and they certainly can still engage in the trauma memory and think about it, and it feels pretty negative to them, but they're not as overwhelmed by it.
Mm-hmm. Thank you. We have an additional question. There are some great questions here. Thank you to all of our audience. They want to know, is there evidence for this treatment to be implemented in a virtual format?
Yeah, well, especially since March, we have been doing a lot, pretty much that's all that we're doing.
Mhm.
And that's, I mentioned the implementation work that we've been doing in the VA. And so we're actually in the midst of training a large cohort of like 45 providers across the VA system when the COVID-19 pandemic hit and everything shifted to virtual. But before that, we also were training some providers who worked in telehealth and were routinely doing written exposure telehealth mode. And so we have learned a lot about how to do it. Actually, we even published a paper recently in Journal of Traumatic Stress describing some of the things that we learned about it and delivering written exposure therapy via telehealth. But we find that it works well. It's better if you can do it using video conferencing. But even some clients who internet access is spotty and they feel like they can only use the phone, we've also had it work well in that format as well.
Yeah, it's especially relevant now.
Yep. And in the implementation, I'll just add this, the implementation, we looked at if outcome findings for patients who had it via telehealth were different, and as well as dropout. And we found that it was not different than doing it face-to-face.
That's great. Yeah, so we have an additional question about clients who might have co-diagnoses such as borderline personality disorder.
Mm-hmm. So that is another moderator that we looked at to see like both severity, so you know, how many access to one other disorders do they have, as well as like depression. And we have not found that that's moderated. So they seem to do just as well. Borderline, we are now in our current studies, we are including a diagnosis of borderline and symptoms to look at this more closely. But one thing that we observed in our prior studies was that people that had, you know, sort of cluster B symptoms, what we suspected was more a borderline presentation, did particularly well with written exposure, which you might not expect. And what I think is going on is that it's so structured and the interaction between the therapist and the client is really more minimized. But the structure in particular, see like people with access to cluster B symptoms seem to respond quite well to, and they got good outcome. So we're looking at that more carefully now by including that as a diagnosis in our current studies.
Okay, thank you. We'll take 2 more questions and then we will wrap up. This question is regarding the manual. For people with multiple traumas, does the manual offer guidance regarding which event to focus on?
Yeah, so that is pretty much a question you always have to ask people with PTSD because, like I said, most people do have multiple criterion A trauma events. And even amongst people that have maybe like childhood sexual abuse and it was chronic, you know, so that's one index event, but there's multiple events within that happened. That is a discussion point. And we do what is also done with prolonged exposure, where we have them focus on the one that is the worst. So what is the one that they have most intrusive memories about? Maybe they have nightmares about. When people have multiple ones that they're like, I can't decide, there's like 3 that were really bad, then it really doesn't matter which one they pick. But we do provide extensive information about how to select the focus of the writing in our treatment manual.
Mm-hmm. Great, thank you. I will note that if we don't get to your question, you can email webinars@adaa.org. And Dr. Sloan, if you're willing, I can send a few over to you.
Absolutely.
Great. Okay, let's get our last question. It's for recommendations for patients with dyslexia who might get distracted by challenges that come with writing.
Well, it's good for a therapist to be in the room, I think generally, because all kinds of things can happen, and it's good to sort of monitor without like staring directly at a person. You're usually just like peripherally having some peripheral vision on them for a variety of reasons. So I think if people get distracted, sort of trying to help redirect them. If someone feels overwhelmed and they want to stop writing, they just stop, you know, also redirecting them to do that. So it's, the therapist stays with the person while they're doing this. So I think if there are those sort of issues that can help redirect them without completely pulling them out of the exposure.
Great, thank you. These were wonderful questions and a wonderful presentation. Thank you, Dr. Sloan, and thank you to all of our participants for your participation.
Thank you. Thanks for everyone attending today. I appreciate it.
Yeah, we would also like to invite everyone to register for our next live webinar on December 10th, Introduction to Radically Open Dialectical Behavior Therapy for Disorders of Overcontrol, featuring Trent Codd. We also invite you to visit ADAA.org to view all upcoming live webinars, as well as our full library of on-demand webinars. We would also like to announce that registration is now open for the ADAA 2021 Anxiety and Depression Conference on March 18th through 19th. Admission includes access to all live sessions, live Q&As, posters, and exhibits over the conference dates, extended access to more than 100 recorded presentations, and the opportunity to earn more than 50 CE or CME eligible sessions, which is wonderful. If you are not yet an ADAA member, we invite you to view the many membership benefits that ADAA has to offer, including year-long access to continuing education webinars such as this one, access to special interest groups, including online peer consultation groups, promotion of your practice in ADAA's online Find a Therapist database, a significant discount to our annual conference, website listings, and much, much more. Visit adaa.org to become a member. And on behalf of ADAA and Dr. Sloan, we thank you all for joining us today and have a wonderful day.